the Progressive Podiatry Project, here to share knowledge, insights and information for you to improve your clinical practice and, most importantly, help you help your clients. Welcome back to the Progressive Podiatry Project for Breaking Down Blisters Part 2. So last episode, we were fortunate enough to have Rebecca Rushton, aka the Blister Pod, join us to discuss the papers that both her and Dr. Doug Ritchie had published. The first one is Friction Blisters on Feet, a critical assessment of current prevention strategies, and their other paper that was sort of an expanse on this, Friction Blisters of the Feet, a new paradigm to explain causation. So welcome back, Rebecca, and I would like to extend a very huge welcome to Dr. Doug Ritchie to the podcast for episode 2, which I feel is going to bend my mind even more than the first one. So welcome, Doug.
Thank you.
And Beck, how are you today?
Yeah, not too bad. Ready to go.
Excellent. So basically doing a little bit of a recap for those that may have not listened to the episode 1 of Breaking Down Blisters, or it has been a couple of weeks since we released that episode. So in that episode, Rebecca was mostly educating me about sort of where the evidence sits as far as the management and prevention strategies for blisters. And a lot of it was a bit more of a general sense. And towards the end of the episode, Rebecca was educating us that from even a podiatric perspective and definitely a biomechanical perspective, there is a lot more that can be done, and it dives so much deeper than what a lot of us as clinicians may even realize. And that's why we were waiting for Doug to join us to unpack that, because he is undoubtedly one of the biomechanical masters as far as podiatric biomechanics go internationally. So one thing that I think would be a good point to start with is when I've spoken to both of you off air, you did mention that when it came to the reviewing process, because they are peer-reviewed papers, there was a little bit of a pushback as far as with the editors and the reviewers when it came to integrating the biomechanics aspect into the management and prevention of blisters. So I'm not sure which one of you probably had more back and forth with the editors in regard to, or the reviewers in regard to that, but I'll just throw the question out to either of you, whoever wants to answer. Could you speak a little bit to that, where the paper may have had some pushback from the reviewers in regards to the biomechanical aspect?
Yeah, well, considering that blisters are really driven by, or at least shear deformation is driven by bone movement in the presence of high friction force, there are mechanical or biomechanical interventions that we can use to reduce the degree or the magnitude of shear deformations within the skin and soft tissue. So it's quite clear to the likes of us as podiatrists that we can use things like orthoses, gait alterations, digital orthoses, heel lifts, and these kinds of things to affect the way the bones move, essentially. We do it all the time. We do it on a daily basis in our practices when we are treating painful calluses, for example, and ulcers. So while there's a lot of research around these things, especially in terms of ulcer management, there's basically none about blisters. And so the reviewers, of course, were looking for the evidence for biomechanical interventions as a blister prevention, of which there really is none, but there is evidence for treating other shear-related skin injuries.
And
I think what was good is they did let us still throw in the fact that as clinicians, we should consider using, quote, offloading modalities that have worked well in our hands for those other pressure shear related injuries, which we treat regularly. So we were able to throw that in there, and also, more importantly, point out that much research is needed specific to friction blisters, whether these modalities can actually have value in the clinical setting.
Yep. So that It's good to see. And it's so when you say that there's the evidence is kind of lacking, was it, so if we're talking about, say, specific podiatric related pathologies that we may manage, like would it be that yes, there may be some evidence that exists for things such as like a rigid plantar flexed first ray and ulceration, but there's not the evidence for rigid plantar flexed first ray and blisters? Is that kind of what they were sort of pushing back against?
Yeah, I mean, that's exactly it. So there's just a lack of evidence in terms of the injury of friction blisters. Yeah, so there's so much work to be done in blisters.
Like most
Yeah,
things,
and for
I guess.
example, the paper has pretty, shows evidence for or against many of the popular interventions. And it's surprising how many studies have been conducted on, antiperspirants, for example, socks, some of these common things we associate with blisters. But I don't think, Rebecca, and I'm not aware of any studies done on specific foot orthosis design, use of orthoses in general to reduce the incidence of blisters in any patient population.
No, but and if you think about what we do on a daily basis, if someone comes in with, issues related to too much load on the forefoot, we can be doing things like heel lifts, calf stretches, mobilizations to the tib fib, choosing the right shoe with a heel height differential, and that's before we even start talking about orthoses. So there's so many things that theoretically are going to work, and we use them successfully on a daily basis. I guess it's also a problem within the podiatry profession is we still aren't fully aware that blisters are driven by bone movement, and so we neglect that whole aspect of the repetitive shear deformation and the potential for orthoses and all these biomechanical alterations that can help.
Yeah, I think just to echo that, what Rebecca just said is so important. I think if there's a final take-home message in our two papers, is we want to make it clear to clinicians that the blisters occur from within the foot, not outside the foot. And clinicians, when they evaluate a patient with a blister, they always immediately look at the shoe and assume the shoe is, quote, rubbing on the foot. And we're trying to get them to step back and realize it's the opposite. It's abnormal bone movement inside the foot. And since we seem to understand abnormal bone movement and loading of the foot, we really propose we're in the best position to look at the etiology of many of these blisters from a mechanical standpoint within the foot, not from outside.
I think that summarizes it absolutely perfectly. So I don't want people to stop listening now because there's still more that we're going to unpack in this episode. But I think that's, a perfect summation of what it is. And before we jump on to the next topic, just to keep it or give us a little bit of a clinical example. So I mentioned the rigid plantar flexed first ray. So could you, Rebecca or Doug, but Doug, I'd probably throw it to you as far as orthoses go. So let's say that we did have someone with a rigid plantar flex first ray and there were some issues as far as bone movement and the shear forces happening there. What would be an orthomechanical, we are speaking hypothetically, and I know it does vary from patient to patient, but from an orthomechanical standpoint, what would you be sort of thinking down the pathway that may need to be addressed in that situation?
Yeah, so you would think that a patient with a rigid plantar flex first ray would be susceptible to a blister directly under the head of the first metatarsal. But in reality, and in my own clinical experience, that's rarely seen because that's a pressure-induced phenomenon. And as we know, blisters are primarily a shear-induced event. Pressure is a component, not to downplay that. But the shearing that occurs in a foot with a rigid plantar flex first ray may actually manifest perhaps in the digits. Usually these are high arched cavus feet, and we see excessive clawing of the digits. And those patients may actually have plantar blisters in the pulp of the toes more likely than they would directly under the head of the first metatarsal.
Mhm.
But to answer your question, I think, you know, whenever I would get a patient in my practice who was a chronic blister sufferer, the most important thing I could do is watch them walk. And I think from a clinical gait evaluation, you can pick up on whether is this really a pressure phenomenon or a shear phenomenon.
Mhm.
You know, more typically, those plantar flex first rays get the typical pinch tyloma medial to the head of the first metatarsal, which is, and that type of callus is probably more of a shear induced lesion, just as it would if they develop a blister in that location. And so they might be undergoing some type of shear motion, a late mid stance pronation, an abductory whip action after the heel comes off the ground that you can visualize and see very clearly with gait analysis. And so I think just as you would explore why is somebody getting metatarsalgia or other so-called bone-induced pain syndromes, we always would intuitively think, let's watch them walk and try to figure out why.
That's a very good point. And speaking to just gait in a general sense, are there any particular phases of gait where the shear forces are more likely to occur? Like, is it sort of just at heel lift, or are there more than one sort of phases of gait where we may see an increase in shear forces?
Well, I'll jump in and then I'll let Rebecca do as well. You know, in our paper, we quoted the work of Metin Yavuz, who has produced more studies relative to shear than anybody on the planet. And I've had the opportunity to actually teleconference with him several times. And we ran some of these concepts by him prior to writing our paper. And his focus was more on the prevention of diabetic foot ulcerations, which he makes a big case, rightly so, are in his mind more shear induced than they are pressure induced. But he developed really the only valid technology to measure shear stress or shear forces in the foot. And he found that while there's two shear events during the walking gait cycle. One is during heel strike and one is during push off. The push off phase is much longer of duration. And for that reason, he felt that it was a more damaging period of the gait cycle in terms of overall shear force or potential shear distortion. So that's why in most running events, we see the location of friction blisters much more frequently in the forefoot than we do in the heel.
Yeah, Rebecca, do you have any insights to add to that? Like in your clinical experience, do you find even, there's more incidence at the forefoot versus the heel when it comes to blisters?
Yeah, I mean, in running, it's definitely the forefoot. In walking, there's a lot of heel blisters. Yeah, I don't really think so much in terms of phases of gait. I'm really focused on, because what Doug has just focused on would be plantar lesions.
Mm-hmm.
Whereas it's important to remember that we can get blisters anywhere on the foot. And so I just literally think about what's happening. How does that bone move throughout the whole? So for the heel, for example, it compresses down at heel strike with the cushioned insole in the shoe. So there's the bone movement going down, obviously, at impact. And then the Achilles tendon pulls on the back of the heel bone as we get into propulsion, at forefoot loading or propulsion. So yeah, just think about how the bones are moving at every point.
That just makes perfect logical sense, doesn't it? So, just to follow on from like this point, speaking to running specifically, Doug, do you feel like, I know that there's so much out there, not in relation to blisters and running, but just in relation to foot injuries and foot strike patterns. So do you feel that even if someone's experiencing some shear related blisters with running, Are there any benefits, or is there any evidence or anecdotal evidence even that you've seen where slight modifications in foot strike pattern or adjusting running form could even be a potential prevention strategy?
Absolutely. And Rebecca and I have had several conversations about this. And we bring this out in the paper, in several parts of the paper. But the evidence, this is very interesting. If you look at some of the research done on ultra marathon events or long multi-day endurance events, the blisters seem to occur more frequently in the first few days. And then as the days progress in the event, believe it or not, the frequency of blisters actually decreases. And one could speculate that these athletes alter their mechanics intuitively to prevent further shear and damage to their feet. They do it intuitively, and within a few days, they develop an adaptive mechanism that's very effective for them. I do think, in terms from a clinical standpoint, again, evaluating running gait and walking gait, you might actually pick up on certain things that you could conclude are contributing to the formation of frequent blisters in a particular athlete. You know, a habitual forefoot striker is going to experience both fore and aft shear at touchdown, and well, let's see, when they land on the foot is sliding forward and the shear force is directed posteriorly. And then when they push off, they push posteriorly, and the shear force is directed anteriorly. But it's all in the forefoot because they're a forefoot striker, right? So that poor forefoot is getting fore aft and aft fore shearing forces during every foot strike. A typical heel striking runner is spreading it out. They're distributing the shear force only in the heel during touchdown and primarily in the forefoot during push off. So a habitual forefoot runner who's getting significant blistering might consider adapting the foot strike to more of a midfoot strike to try to bring that shear event back to the back of the heel or the midfoot and spare the forefoot. This again is very speculative, but these are things that we're trying to get clinicians to start thinking about, because that's the mechanics of these blisters. It's not from the shoe rubbing on the foot.
And another one is blisters under the heel, which aren't very common, but you're more likely to see them with a lot of downhill running and walking, and just striking with the heel a bit closer under the body rather than a large stride. Well, it makes intuitive sense that that's going to reduce those blisters.
Well, you know, Rebecca, I'm actually curious because you got interested in this because you were a sufferer of heel blisters. I read that on somewhere in one of your bios. Is that right?
Yeah, that's true.
So what do you think caused, and yours were posterior heel, weren't they?
Yeah, posterior heel blisters, the common old heel blister. Yep.
And so what did you finally figure out was the cause?
I don't understand what the cause is. I feel like a while ago I had access to some pressure plate, force plate type stuff, and I seem to remember that I had a relatively delayed heel lift. So I wonder whether it is to do with the velocity of the heel moving up relative to this, obviously the stationary skin, because of high friction force. So the pull of the Achilles at the back of the heel. I don't know. I've just kind of assumed that I've got relatively blister prone skin, in that there's a relatively low resilience to repetitive shear deformation.
You know, I was thinking about it after I read that for you, and I know you've posted things about posterior heel blisters. I think another area to think about is just the attitude of the lower leg and the foot at heel strike during running. And Talicia could verify this. You know, we try to teach runners not to overstride, but picture an overstriding runner at heel strike. They've now angled the leg and the foot to the ground to actually increase tangential shear versus vertical impact force. You know, the more they overstride, the more there's horizontal directed force on the foot than vertical.
Yeah,
And
I've actually thought that that might be part of my blister issue as well, because I'm relatively short in stature. And so to sort of keep up with everyone, I guess I'm trying to take longer steps, longer strides. So yes, I have considered that as well.
Yeah, I think the posterior heel blister is really probably more likely due to the initial foot strike, particularly in a heel striking runner. And I think that could be modified with a more vertically oriented, less overstriding. As a typical example, to answer this question in a long-winded answer, yes, gait modification, I think, can be a profound intervention for prevention that thus far is very much overlooked.
And that's a really good point. And so you mentioned, Doug, with my experience with running. So looping it in, because I know I've spoken about this in a few podcast episodes previously and webinars on this. So, and what Rebecca and Doug are speaking to is there's one particular case study, I can't remember what episode it was that I was talking about this. It was diffuse anterior knee pain in a runner and that overstriding. So that's often where, yeah, like Doug was saying, there's less vertical ground reaction force and there's more of that forward shear happening at the knee. And some of the gait alterations that we do with those clients to help decrease that anterior shear at the knee is, one, we're looking to increase lower extremity neuromuscular stiffness, but also increase their cadence and decrease their stride length. And even by increasing cadence, you will often decrease stride length. And then depending on what's happening, if we're looking to wanting to increase neuromuscular stiffness, sometimes introducing gait training and or plyometric work in that comes into the equation. But it's a blister episode today, but it's just trying to give people a little bit of an insight to loop it into topics that we've already spoken about before. So the mechanisms that Doug and Rebecca are speaking to are very similar or almost the same as those who are overstriding with potentially that anterior knee pain. So the mechanisms that we may use to address that would likely be similar or the same, depending on the patient that we're dealing with. It just highlights that the variation in human movement is quite profound. And all of us have our weaker points. So we might have two different people that are both overstriding with running. One may end up with the posterior heel blisters. The other person may end up with anterior diffuse knee pain. It just depends on the rest of their mechanical profile and their load tolerance. So expanding upon gait and running, because we were talking about foot strike patterns, one thing that we've all seen over the last couple of decades is talking about sort of the evolution of running and people sort of fluctuating between the barefoot running phenomenon and running in maximalist shoes. So going back to basics, if we take the modern technology and modern running out of the equation, so we've got all of our changes in footwear, the changes in running surfaces. If we think about just Homo sapiens in general, pre all of the changes in the running surfaces, Doug, I'll throw this question to you, and it's a little bit left of center, but do you feel that the surfaces that we're running on and the changes, say with footwear and how it alters how our feet strike the ground, if we take all of that out of the equation and we're just Homo sapiens walking on natural surfaces or running on natural surfaces, do you feel that we would have been just as likely back then or in those situations to experience blisters, or is it kind of a bit more of a, say, modern phenomenon?
To answer your question, no, I don't think I don't think our ancestors developed blisters near as frequently as we did. For obvious reasons, they didn't wear shoes. And by the way, shoes are a component of this whole paradigm. But if we go back and look at how the human foot adapted for upright bipedal ambulation and really for endurance running, which is how our species evolved to become very efficient hunters and survivors in the world at that time, a lot of the adaptations were to improve running efficiency, and not the least of which was to improve traction on the ground. And the human foot is innervated with, from the sympathetic nervous system, nerves that activate the eccrine sweat glands that release moisture to improve traction. And improving traction with moisture on the plantar surface of the foot improves efficiency. And everything that our body and our feet did to adapt for upright ambulation as a species improved our efficiency in ambulating and improved energy conservation. And so, ironically, some of those things to improve traction, for example, improve friction force of the foot against the ground, can actually predispose to blistering. And so there's a fine line between enhanced performance with good traction, which is what running shoes do, and what certain surfaces have better traction than others. The end result is better performance, but the more you increase the friction coefficient of the foot against any surface, the more you increase the chance for blistering. And so it's an interesting comparison, but I think ideally the human foot adapted to run on forgiving surfaces from a coefficient of friction standpoint. Grass, sand, dirt have a certain give. They're not high friction surfaces like an insole of a running shoe. And so I think that in the natural state, the human foot was not as blister prone as it is today in the confines, not just of an ill-fitted shoe, but a shoe that has a higher coefficient of friction than a natural surface.
Rebecca, do you have anything to add to that?
No, Doug's explained it eloquently.
So essentially what I'm interpreting this as is the human body, we were built with natural mechanisms for ourselves to increase traction. But then when we're throwing other elements into the equation, like running shoes, which also look to increase traction, then it creates a little bit of a fine line that we have to walk where we're not overcorrecting it because what the human's body does versus what the external apparatus, be it socks or footwear, does, that can actually give us too much of a good thing. Or not
exactly. And I think you folks touched on this in the previous podcast, but I wish to emphasize it again, is that the human body also possesses an ability to adapt to alterations of friction and even probably moisture, where the deeper tissues in the foot can adapt and become more resilient and less prone to the blister event. And we can't overlook that with gradual adaptation to running surfaces or running shoes, the foot does adapt and may in fact find an equilibrium where it's not going to suffer a blister every time you go out and walk or run.
Yeah, the work of Wang and Sanders mainly in this space, looking at the adaptive changes within the skin, have found that it occurs sort of by day 7. And keeping in mind, though, this was looking a lot at amputation sites, so we're not looking at the thick skin of the plantar surface, but it seems to occur relatively early on. You might think it takes a longer time for the skin to adapt, but in fact, it starts quite soon after those shear load episodes. So to increase the resilience to shear deformation, we have to actually give that part shear deformation. We have to impart that force so that it can build the adaptions.
You know, to expand on this whole little area, I wanted to throw this out. I periodically send little email cutouts to Rebecca from the States here, and I heard a lecture a while back on comparison of overground running to treadmill running. And one little part of the lecture just jumped out at me. The presenter showed that the friction force under the foot on a treadmill is less during push-off than it is on overground running. And that makes sense because the treadmill's moving under your foot.
Yeah.
You know? And he was pointing it out. There's actual kinematic studies that show adaptation to that. And I said to Rebecca, I said, you know, maybe that's a good point. If you have a client who habitually trains on a treadmill for various reasons, but then they go out and run a 10K race, they're probably more blister prone because their foot hasn't adapted to the higher friction force that they would on overground running.
Particularly at propulsion, yeah.
On the other hand, you could use a treadmill to allow a runner to run without blisters, perhaps if they're really highly blister prone for certain reasons, and gradually let them adapt before letting them go out and run overground. That's kind of a wild concept too.
Well, that's exactly where my mind was going when you first mentioned the treadmill, because that just made perfect sense. And that's exactly what I thought, because it's like Rebecca and I were discussing in the first episode, we're pretty much all collagen, regardless of if it's bone, skin, muscle, tendon. And we were talking about the concepts of progressive overload for adapting to loads to make us more injury resilient. So that's exactly what I was thinking. Potentially, if you've got someone starting them in this case, it'd be a lower shear environment using the treadmill, and then gradually introducing some higher shear activities, which would be the road running and different surfaces. So that was, yeah, good. Yeah, we're on the same page.
Yeah.
There's one thing that I want to throw the question at both of you. And Rebecca, we did speak about this during the first episode. So we've been talking about footwear, the internal structures of the feet, biomechanics, and what I want to expand again on, because we are sort of delving into running a fair amount, is when it comes to socks, because it seems that we've got the bony interface with the skin, and then we've got the foot's interface with the shoe, but socks, more often than not, are the middleman in that equation. So with what we've been discussing and how footwear plus the natural mechanisms that the human body does to increase our traction, socks being the middleman, what would be sort of the ideal sock that we're looking for to, if we've got someone that is blister prone because they are getting too much of a good thing, the traction from the shoes plus the traction from their skin and the sweat, what would be the sort of ideal sock scenario in that case to help attenuate or decrease the risk of blisters?
That's a really good question, and if only there was a really simple answer. But and I'll let Doug speak to this because he's the expert on socks. He did some really important sock research in the 90s. But socks can potentially play a few parts in blister prevention. So it's a moisture management strategy. So moisture management is a strategy that aims to reduce the coefficient of friction. So socks, in essence, can reduce the coefficient of friction between the skin and the sock purely by dealing with the moisture. And also they can cushion. So they can reduce the vertical force or the perpendicular force if they're relatively thick, and that can reduce friction force. And if they are thick, they can also absorb shear load. So the sock itself can undergo a little bit of shear, and it can take up a little bit of that shear deformation, leaving less of it to occur at the skin. But I'll let Doug go from there, and let's hear what he has to say.
Well, that was awfully good. I'll tell you, I don't think I could do any better, Rebecca. But,
Come on.
Well, early on when I was doing my sock research, everything we tried to correlate with our findings was this phenomenon known as wicking. And we were comparing cotton fiber socks to synthetic polypropylene socks. And because the synthetic fibers perform better and the laboratory tests confirmed that cotton was absorbed moisture but didn't wick moisture away from the skin surface, it was all about wicking. But in the subsequent 30 years, and with further research that's been done in this area, I'm convinced this whole idea of wicking is really overblown, and I really even question if that process occurs inside of a shoe. I like the term moisture management, which Rebecca used, because it's a general term really referring to how does a sock itself manage moisture. Wicking is only one way it does that. For example, wool has an ability to absorb a lot of moisture, but when it absorbs the moisture, it still behaves in a very positive way. The fibers themselves still are resilient, they're elastic, they stretch and recoil. They still maintain their cushioning properties, whereas cotton doesn't. Cotton fibers, once they're wet, they flatten, they get distorted. The sock itself doesn't fit well on the foot. It bunches and wrinkles. And so we're looking really today at the physical performance of a sock when it's wet. I mean, given it's inevitable, this sock is going to get wet because the human foot produces moisture during physical activity. And it's the behavior of that material and the construction of the sock that ultimately determines whether it's going to either help cause a blister or help prevent it. One final piece of research we found, aside from the factors that Rebecca mentioned, is the frictional properties itself of the sock, notwithstanding moisture. For example, terry weave socks that have the loops, so to speak, have been shown in laboratory tests to actually increase friction coefficient on the foot compared to a smooth weave, or what we call a flat knit sock. And I would have patients come in my office invariably who told me they couldn't wear terry constructed socks. They had to use a flat woven construction. And at first I thought it was in their head, but now I can see, and some of these laboratory studies confirm that. In the end, we don't have a lot of really good studies to show us specifically what the ideal fiber and the ideal construction is. But we have some general guidelines that we give, and Rebecca touched on that. I'd say if I had to come down to one general recommendation, I would say that socks that have padded construction and are composed primarily of wool fibers generally perform better in clinical trials than any other type of sock.
Yep, that's a very good summary. So and I think that point that you hammered in on, or it's the performance of the sock when it's wet that will give us the biggest determinant. And I guess that stands to reason that it's always recommended if you're going out for a day hike, always take a pair of socks, because once you're on your way to blisters, it's just a nightmare to unpack if you can't change that environment, I guess.
Right.
Talking about, so I just want to circle back to orthoses, because talking at it from that podiatric perspective, and we're talking about different materials of socks, are there any particular materials? I believe, was it Spenco that you were mentioning last time, Beck, that's kind of, if we're looking for orthoses top cover materials that might be the most, say, blister friendly, would it be Spenco that you would recommend? Yes. Or are there other options available?
They've looked at Spenco and Poron, and Spenco outperforms Poron. So that is what I would go for. So the mechanism there is, number one, it cushions, but number two, and quite importantly, it absorbs shear. So it's a closed cell material, and the researchers at the time kind of described it like a ball bearing effect, so that the discrete ball bearings are able to slide or move or translate across one another. So when there's a bit of shear being taken up by an external material, then there's less shear that's left to be taken up by that soft tissue sandwich between skin, surface, and bone.
Yeah, and Rebecca, compare that to Plastazote from that study. Remind me of coefficient of friction of Plastazote compared to Spenco.
Yeah, so when they were creating Spenco, it's in neoprene, and they quickly found that they had to put a top cover on the neoprene because the coefficient of friction was so high you couldn't even slip your foot into the shoe over that insole. So that's why they've got that green or blue material on the top. So they've reduced a little bit of coefficient of friction because it's actually, we can't afford for it to be too high such that you can't even get your foot into the shoe. Yeah, so that's an interesting little point. But Spenco frequently outperforms Plastazote from memory in terms of when it's wet, especially.
Yeah, and this brings up a whole, I don't even want to go too far into this because and it could be a future podcast, but all along Rebecca and I have gone back and forth saying, how much of this pathomechanics is related to neuropathic diabetic foot ulcerations? And how many of these strategies to reduce friction blisters would be efficacious for the diabetic patient? And the bottom line is they're very relevant to each other. And I've yet to find a diabetic foot researcher who disagreed with me in saying that a diabetic foot ulceration begins under the skin surface the same way that a friction blister does. And so why aren't we looking more at shear forces in the diabetic foot rather than direct pressure? In the diabetic foot, everything's to do with pressure. And why aren't we looking at shear reduction strategies for the diabetic patients? And some of the studies that we've quoted are from a fellow named Marty Carlson, who spent a whole lifetime trying to teach this to clinicians around the world, is the role of shear in ulcerations, not just in the feet, but in the sacrum and bed sores and other areas. So I look at these studies of coefficient of friction of footwear and insoles, and it's mind-boggling to see that some of these most popular insoles that we use in offloading the diabetic foot actually have the highest coefficient of friction, which isn't good.
No, that's very interesting. And it makes perfect sense because, like, I don't work in the high risk realm by any means, but even what I've been exposed to literature wise, there is quite a lot that when I'm learning from people discussing high risk, it's sort of, a more deeper breakdown that becomes superficial as time goes on. So it makes perfect sense. So it is a bit curious that it's not following that logical path of addressing shear.
And when we're looking to reduce the incidence of blisters and ulcers, we really, a lot of times we get hung up on looking for one solution that's going to work for every blister location in every situation, but we really need to get anatomically specific. So we need to think about the site where the blister is occurring and what the bone is doing there. We can reduce the coefficient of friction at that site just to free up that skin a little bit to move more in sync with the bone and leave high friction elsewhere for traction, which we need for the efficiencies of gait. But there's no reason why we can't really reduce it significantly at that problem area or at that at-risk area to reduce the shear load deformation, the shear deformation magnitudes.
And I think that even just the point that you mentioned right at the start there is where people are looking for that kind of one simple solution for all anatomical sites. It goes the same with musculoskeletal pathologies, where often people will want the one perfect exercise for treating Achilles tendinopathy or plantar fasciopathy, where it's so multifaceted for the individual. So considering the individual factors that are feeding into that person's clinical presentation, it would go exactly the same with all the individual factors that feed into the presentation of an individual's blister.
Yeah, couldn't agree more.
Right. So just, I do want to hammer on to the ortho, because I do know that I'd say it's about 95% of our listeners are podiatrists or have an interest in lower limb biomechanics. So I just wanted to throw out, even if it's a yes or no. So two of the other very common top covers that are used in orthoses are the EVA, like the 2 mil. That to me seems like it has a high, when you're mentioning, so Spanko without the blue or green top cover, It's got a very high coefficient of friction. EVA seems to have a relatively, not as high as an uncovered Spanko, but EVA does seem to, like, just think about when you're prescribing or fitting a pair of orthoses and it's the EVA 2.0 top cover, someone trying to get their foot into that shoe. Would you say that the EVA is potentially a mechanism of causing blisters because of that friction?
Well, we discussed this in the paper. One could argue that a full-length EVA top cover with a high coefficient of friction improves the efficiency of the foot on top of the orthosis, particularly in a runner, for push-off. You don't want the foot sliding off the orthosis.
Mm-hmm.
But then again, it may be that that material in a certain area of the foot in a certain runner is creating high friction force and therefore increasing the chance of a blister. That brings out a very effective strategy, and that's targeted coefficient of friction reduction using friction reducing patches, as is discussed in the paper. And Rebecca has a lot of stuff on her website about this and in her course. So that's the key, is if you're going to reduce coefficient of friction, it doesn't necessarily pay off for the runner to do it in a global fashion under the entire foot, but targeting it can be a very effective intervention.
Yeah, absolutely.
That makes sense. And so when we've got, because I know that there's been some clinics that I've worked at where they will opt for just vinyl top covers for their runners. And so vinyl, it seems that that would have a very low coefficient of friction. There'd be a lot more sliding. So would that be potentially going too far the other way?
Yeah.
In my opinion, yes. But I'll let Rebecca answer.
I don't think there is research on vinyl. I know there is for leather. Leather's relatively high friction, particularly when it's wet. I don't know of any research about vinyl top covers. But yes, it makes intuitive sense. Yeah.
So I just wanted to get both of your opinions on that, because I know, so many podiatrists, they kind of opt for their sort of one go-to top cover. So it's good just to unpack, and because for me, that's painting a little bit of a picture of sort of the spectrum of where different top covers may sit, but then also things that we may consider if we are seeing, say, a runner that's experiencing plantar forefoot or digit blisters as a result of running. So considering the spot reduction and or the top covers that we're using for their orthoses may be beneficial.
Yeah.
I think one thing, and you've emphasized this through this, and friction blisters are multifactorial. And when we evaluate a patient who's got chronic recurrent blisters, we have to consider all parts of the mechanism. And certainly the top cover material, if the patient's wearing an orthosis, or even the stock insole of the shoe, have to be considered as something to perhaps change or modify, along with many other factors.
So throwing another curveball at you, and again, this is hypothetical because it's one example of one problem. Say we're dealing with an abductory twist, which is one of the most common, or the heel whip, which Doug, you mentioned a lot earlier in this episode. So dealing with an abductory twist, yes, there may be mechanisms local to the forefoot that we may be looking at addressing. But in that situation, if we're looking at it from a global perspective of mechanical loading, would the utilizing a heel lift or going into a shoe with a higher heel offset, would that potentially be a mechanism that you would or wouldn't use or consider in those certain presentations?
Yeah,
if it's related to reduced ankle dorsiflexion range?
Yeah, I mean, there's all kinds of, not all kinds, but there's several theories about the abductory twist. But one thing most of us agree on, it becomes apparent after heel rise. It's after the heel comes off the ground that you see this sudden transverse plane whipping of the heel laterally. And one of the thoughts is that the foot is trying to abduct due to the pronatory force, whatever it is, of the tendo Achilles or some other factor during mid stance, but because the heel is on the ground, you've got much more contact surface area. And the minute you lift that heel, now the foot is only on this limited area. Now the whipping action can really get engaged. So one could theorize, and I've used this before, that putting a heel lift more or less it really delays the heel rise, so to speak, or spreads it out over time. And that would be one mechanism. But the really underlying primary mechanism is try to reduce the magnitude of pronation during loading and mid stance with any orthotic strategy that you use to reduce, quote, pronation. Because pronation early in the stance phase of gait is what theoretically induces the abductory twist later.
Okay, that makes sense. I think we will grab you back for another episode, speaking even more on biomechanics, because I know that you and your brain could talk to it for years and years, which I would love.
Yeah.
So with that, I do very much appreciate both of you coming on, and I've enjoyed this deep dive on blisters. So in regards to the mechanical aspects and all the things that we've covered today, I'll throw it to Doug first and then Rebecca. If you had any take-home messages or key points that you'd like our listeners to leave today. I know early on there were a few very good summaries that came out, but if you could, throw a couple of takeaways that you feel would probably be the most important, say, considerations for clinicians when they're assessing and addressing blisters with their patients.
I think, like many of these injuries, going back to taking a simple history is so important, because what baffles me, and I've talked to Rebecca about this several times, is when you get a seasoned athlete, an experienced athlete who's trained for years, and they suddenly have a bad episode of blistering, whether it's in a race or the week prior to a race, and you realize something went wrong there. And taking a history is so important, because you can pick up on things like, well, the obvious is, did you change socks? Did you change shoes? Did you change running style? Did you change surface? Did you change the style of training? But you have to ask all these questions because something went wrong. Something changed a while ago that made this happen. Why would a seasoned runner who never blistered before suddenly blister? And so I look at that, and then take a really good history, ask the right questions, delve into all aspects of the pathomechanics, because there's some ingredient there that probably tipped the scale. And then don't be afraid to intervene, multifaceted, but don't forget to overlook the mechanics. That's what we're trying to get at. Don't immediately say you got to buy bigger shoes, or don't immediately say you just put moleskin over it the next time you go out and run. You're totally missing the opportunity as a thinking clinician, using the same diagnostic tools you use for tendinopathy, as you teach. You have to delve into the underlying mechanics of the problem in order to come up with a viable solution.
Yeah, look, I really agree, Doug. I think that there is more that's predictable about blisters than is unpredictable. And as podiatrists, I think it is our job to help our patients not sort of get hung up on, blisters just happen for some unknown reason. There's usually a reason. There's been a change somewhere, and literally just trying to find that factor that has changed to understand it can help them feel more in control of blisters, in that they are preventable, they're predictable, and there are definitive ways of treating them. And if I was to say one thing to podiatrists, don't just go straight for taping. I know it's easy to think that blisters are caused by something rubbing on the skin and that they're a superficial to deep wear injury, but indeed they're an intraepidermal tear. And putting tape on the skin, yes, it might spread shear load a little bit and reduce peak shear, but shear is still happening underneath that skin surface. So get really anatomically specific and think about all the mechanisms that are available to you for blister prevention.
Well done.
I think they're both absolutely amazing takeaways. And I don't know about everyone else listening, but for me, even from the first episode, realizing when we're talking, again, because it's collagen structures, just how similar the mechanisms and the management are, in the sense that it all comes down to our clinical history and addressing the individual factors. And when we're dealing with, say, musculoskeletal injuries in a muscular or tendon sense or fascia sense, even though we can't 100% predict if someone will sustain an injury, there are some pretty profound red flags that we can identify that will increase someone's risk of developing an injury. And I think it's your summaries now just highlight exactly the same things that we do when we're taking our clinical histories. It applies to blisters. So they're not this unique dermatological phenomenon. It still comes down to individual load and good clinical histories that will help our management. So I've gotten so much out of both episodes. So I am looking forward to wrangling you back in for episode number 3 if you're keen.
Anytime.
Absolutely.
So I've really enjoyed it. And again, thank you both. So Doug, if people that are listening would like to get in touch with you to learn more, where would they be able to find you? Either email address or website, if you've got one floating.
Let's see. My email address is on my, if any of you are on LinkedIn, it's on my LinkedIn profile, but it's basically my name, D Ritchie Jr. and I'm still on good old fashioned AOL.com. And then you can also contact me through my website for the Ritchie Brace, which is basically www.ritchiebrace.com. And Ritchie is always spelled Richie.
That's good to know, because I know when I first was learning about the Ritchie Brace, oh God, years and years and years ago, I would always misspell. So take the T out of the equation. Rebecca, I know we covered it in the last episode, but I'm assuming there's going to be new people listening. So where can people find you and find out more about blisters?
Well, we've got a new website for podiatrists, which would be really handy. So it's pro.blister-prevention.com. Go on there and have a look at the lots of resources that are available to you if you want to really up your game in regards to blister management. And you can contact me. There's contact pages there.
Excellent. Thank you. And if people forget all of that information, if you go to progressivepodiatryproject.com, head to the P3 Partners section, we'll also be able to find Rebecca there, and it will direct to her website. So again, I want to extend a huge thank you to both Doug and Rebecca for joining us today. I've personally got so much out of it, so I hope the listeners have too. So thank you, and hopefully we'll be able to organise another round if you're keen, because I feel that there's still so much more that we can discuss.
It's a pleasure. Thanks, Talisha.
All right, thanks,
My pleasure
guys.
as well.